Good morning, everybody. I'll foster a vibrant civic life in our hometown of Philadelphia. This includes our work to support the region's health and human services sector and our arts and culture sector. It also includes our local research efforts to inform discussion on important issues facing the city and the region. On a national scale, we are a research and policy organization that works on issues concerning health, economic, governing, and conservation problems. As you know, Philadelphia and other jurisdictions across the country are facing an opioid crisis. In this city alone, there were 1,217 accidental drug deaths in 2017, 88% of which involved opioids. What I have come to understand about the crisis is how far-reaching and unrelenting it is. For those struggling with this condition, it turns their lives upside down, and yet the shame and stigma they can experience can make it hard for them to get the help they need. Moreover, the crisis has created chaos for families and communities, and it takes a toll on the frontline staff who are trying to help those affected to get on a better path. Today's conversation on increasing access to medication-assisted treatment, or MAT for short, is so important. It also stems from Pew's own research on the intervention and is an extension of an event we held last April. At that time, a panel of officials and experts from Philadelphia and other jurisdictions discussed a range of strategies being employed to address the crisis, including access to treatment. Opioid use disorder, or OUD for short, is a treatable chronic condition. Whether an individual is dependent on prescription opioids, heroin, or any combination of these drugs, extensive research has shown that MAT is the most effective intervention. It combines Food and Drug Administration approved medications, which include methadone, naltrexone, and buprenorphine, with behavioral interventions such as cognitive behavioral therapy. The medications are prescribed to relieve withdrawal symptoms or block the effects of opioids while the patient receives counseling and other supports. Evidence shows that MAT significantly reduces illicit opioid use compared with non-drug approaches, and that increased access to these therapies can reduce the risk of overdose deaths. It also helps people return to the workforce and to their families. But just like treatments for other chronic conditions such as diabetes, finding the right medication may be different for each individual. This is why officials and care providers like those you'll hear from today are working to remove barriers and expand access to all of the medications used for MAT so that patients can receive the care they need and achieve the best possible outcomes. We have assembled two panels for today's discussion. The first comprises public health officials from Philadelphia, Pittsburgh, New York City, and Cincinnati, who will talk about the innovative and promising practices they have employed or are undertaking to expand access to MAT in their jurisdictions. The second panel consists of Philadelphia-based providers from 3 care settings where MAT can be administered: an emergency department, a primary care practice, and a treatment center. They will discuss their experiences on the front lines of the crisis and what they think should be done to remove barriers and improve coordination of care. We think these conversations will be helpful not just for Philadelphia and the other jurisdictions represented by our panelists, but also for other cities and counties across the country and the providers within them that are facing a similar problem. I want to personally thank all of our panelists for being here today to share their perspectives. Now, before I introduce our moderator, just a few housekeeping items. Today's discussion is being live streamed and live tweeted from @PewHealth, and we encourage those of you in the room and watching online to participate in the conversation using the hashtag #PewTalksOpioids. For those of you in the room, You should have a packet of information that includes today's program and some of Pew's research on this topic, all of which can be found on our website at pewtrust.org/PhilaOpioids. Lastly, as a reminder, please silence your cell phones and keep your conversations to online only so as not to distract the panelists and other audience members. And now it's my pleasure to introduce our moderator, Beth Connelly. She is the project director for the Pew Charitable Trusts Substance Use Prevention and Treatment Initiative. Prior to joining Pew, Beth served in government for 30 years, including as the Human Services Commissioner for the state of New Jersey. Beth will tell you more about Pew's research and work on expanding access to MAT at the state and national levels, and will introduce our panelists. She will be facilitating both of today's conversations. Once again, thank you for joining us. We are grateful for your time and your commitment to this life-saving issue. I'll now hand this over to Beth.
Thank you very much, Frederica. I appreciate the introduction, and good morning. It's really exciting and uplifting to see so many people here today and know that there are so many more joining us via our live stream. Again, I'm Beth Connelly, and I direct the Pew Charitable Trust Substance Use Prevention and Treatment Initiative. Pew's Substance Use Initiative works collaboratively with states, providing tailored assistance around actionable policy recommendations and guidance to address the opioid crisis. Pew's current state technical assistance work focuses specifically on increasing access to medication-assisted treatment, evidence-based treatment for opioid use disorder. And I know that many of you know that MAT is the gold standard for treatment of opioid use disorder. For a little context on why access is so important, in 2017, roughly 20 million Americans struggled with dependence on alcohol or drugs, yet only 1 in 9 received any kind of treatment. We know from the National Survey on Drug Use and Health that not everyone is ready for treatment, but we also know that some individuals do not have healthcare coverage or cannot afford treatment, and yet others feel stigmatized by either their family, their friends, or people at their workplace. Local government and communities across the country are working hard to address treatment gaps and expand access to MAT. The experts comprising our 2 panels are using a variety of strategies in their cities, counties, and healthcare settings to assess and improve their systems, as well as reduce barriers for patients who need treatment. Each panel will offer insights from both public health official and care provider perspectives, and we hope you come away with a better understanding about what's being done and what can be done at the local level to increase access to MAT, whether you work here in Philadelphia or somewhere else along the country. Today is an opportunity to learn from experts, to learn from one another, and to take the lessons back to the communities we serve. So just a little bit about the organization for today. Each panelist will provide us with an overview of their experience and strategies. I will ask a few questions, and then we will open up questions to the rest of the room. And I hope you will be prepared to ask some really great questions because we have so much insight that you can really gain from. Then we will open it up to our live stream audience. And again, live stream audience, you want to tweet your questions to @PewHealth using the hashtag #PewTalksOpioids. Following this discussion with our public health officials, we will transfer to our provider panel, and we will then go from there. So let's start with our first panel today, and I'll go up here and introduce them to you. So let me introduce you to Marissa Kaplan Dobbs, and she is a primary care initiatives manager for the Bureau of Alcohol and Drug Use Prevention, Care, and Treatment at the New York City Department of Health and Mental Hygiene. Next, we have Eric Holsey, the manager of behavioral health analytics for the Office of Data Analysis, Research, and Evaluation at Allegheny County Department of Human Services, which includes Pittsburgh. We have Timothy Ingram. Commissioner Ingram is the health commissioner at Hamilton County Public Health, which includes Cincinnati. And finally, we have the commissioner of the Department of Behavioral Health and Intellectual Disabilities here in the city of Philadelphia, Commissioner David Jones. So Ms. Dobbs, Captain Dobbs, can you please just open up by telling us a little bit about your organization and the work you're doing?
Sure. Thanks so much, Beth, and thanks everybody from Pew to having me here, and for everybody in the audience for showing up today. So I'm Marissa Kaplan Dobbs, and I'm at the New York City Department of Health and Mental Hygiene. I'm in our Bureau of Alcohol and Drug Use, Prevention, Care, and Treatment. So in 2017, there were 1,487 drug overdose deaths in New York City. That's one person dying every 6 hours of a drug overdose. 2017 had the highest number of drug overdose deaths ever recorded. In response to this, New York City has invested in a plan called Healing NYC, and that is composed of preventing overdose deaths, preventing opioid misuse, and connecting New Yorkers to effective treatment. One of the flagship strategies of this is expanding access to buprenorphine, and we have several initiatives to do that. One of them is our buprenorphine training and technical assistance initiative, in which we're training 1,500 new buprenorphine prescribers and providing them with technical assistance to implement it into their practices. We also have a buprenorphine nurse care manager initiative where we're funding 26 safety net primary care clinics across the city to have an RN level nurse care manager whose function is to support new buprenorphine prescribers, the clinic staff, and be the primary point of contact and facilitator for patient care, for buprenorphine patient care. We're also promoting buprenorphine prescribing and induction in emergency departments and offering them technical assistance to do so. We're funding harm reduction programs to implement buprenorphine treatment there to offer to their clients who are already receiving services. And we have a public awareness campaign called Living Proof, where New Yorkers in buprenorphine or methadone treatment give testimonials about how treatment has impacted their lives. And these ads have been running on social media, television, subways, buses, that sort of thing.
Thank you.
Yeah.
Eric, would you like to introduce yourself?
Good morning, and I'm very thankful to be here, and thank you for coming this morning. I serve as the manager of behavioral health analytics in the Department of Human Services, which includes homeless services, aging services, child welfare, and a variety of other services that don't have a distinct program office. And I work within an analytics unit that supports these program offices, one of them being the Office of Behavioral Health, and we work pretty closely with our Public Health Department, which is a separate county agency. And some of the things that we have led and promoted are expanding contracts with our methadone maintenance and other specialty substance use treatment providers who are able to prescribe buprenorphine. We sort of steward our Medicaid program locally, just as you do in Philadelphia, and so we can work with our insurer to expand these kinds of contracts. Also, like Philadelphia and Pennsylvania, we have the Centers of Excellence, and we have several in our region. And the aim of that is to have a person, one of the key factors is to have a person with lived experience out in the community, meeting people in hospital or elsewhere they may present with opioid use disorder, to bring them back to a hub center that's able to prescribe medicine and provide the counseling for someone seeking treatment. Another thing that we do is we publish things much like Pew, and we put out a position statement with the health department, the insurer, the oversight organization in our department on taking positions and stands on medication-assisted treatment. Things like criminal justice shouldn't be driving the treatment. It should be, a health professional and a person's decision to talk with their physician or health professional to make those decisions. Another thing that we're trying to do is to assess our treatment providers' capacity or capability to deliver medication-assisted treatment, whether or not they have a prescriber on site, they have an MOU, some other arrangement, what does their board believe about medication-assisted treatment. And then finally, while we don't have a reach in our emergency department, we do work collaboratively and promote buprenorphine induction when people do present to the emergency department, and that has just begun last fall. So,
exciting, good stuff. Commissioner Ingram.
Well, good morning, and I also thank the Pew Charitable Trust for having me here, and the rest of us, and thank you for everything you're doing to try to prevent this and mitigate this terrible, terrible epidemic of opioid misuse in our communities. 2016 and in 2017, Ohio had the second highest overdose rate in the nation. And Hamilton County, being the third most populated county in Ohio, was a big contributor to that. As a matter of fact, we were looked at as kind of the epicenter for a while of the nation, especially when carfentanil became available on the streets, which caused massive overdoses in 2015, 2016, and also caused a lot of deaths because no one actually knew what we were actually working with. We gathered some people and said we have to do something, especially in 2017, which is obviously is going down as a very, very terrible year in our country and in Ohio for the number of young lives we've lost to opioid overdoses. And so one thing we came up with is gathering up and said we thought if we could keep people alive, prevent secondary infections until we can get them into treatment, what would that look like? And so we developed a project called the Narcan Distribution Collaborative, which is how we've been using basically to spread the news about medication-assisted treatment as being a best practice, because it was not being used in Ohio widely across our providers and so forth, behavioral health as well as, of course, our medical providers. So we basically was able to remove the barriers of cost for Narcan and begin to distribute Narcan, about 30,000 doses, as a matter of fact, in about 15 months, while we were into the hospitals, into the communities, into the people's hands, family members and so forth, letting data drive us where it should go, because the idea was to keep people alive until we can get them into treatment, until they're ready for treatment. And while we were doing that, we were educating the providers about medication-assisted treatment, and we continue to do that, and now we're starting to see some progress. As a matter of fact, not only was we trying to keep people alive through a massive naloxone distribution project, but we're also trying to open up treatment on demand so that we have real-time data on where the slots are based on what substance use disorder you're dealing with and what insurance you have or do not have. And the other thing that's been very difficult, but it's starting to see some progress in Ohio, is integration between what I'll call the physical health system, the medical system, and the substance use providers, the behavioral health system. In Ohio, those two systems are quite separated. And as a matter of fact, in Ohio, although we have mental health boards in every state, Ohio law prohibits mental health boards from providing any direct services. So they have to use, they're brokers of money, and so they have to use the not-for-profit organizations of behavioral health, and many of them do a great job, but some of them have been slow to adapt medication-assisted treatment as a best practice. So anyhow, these are some of the things that we're doing in Ohio.
Great, thank you. Commissioner Jones?
Thank you. Certainly want to thank Pew for hosting us, and thank you all for coming out this morning. I just want to set a little broader context. So, and I should back up to say, so I am David T. Jones. I am the Commissioner for the City of Philadelphia's Department of Behavioral Health and Intellectual Disability Services. It's a bit of a clunky acronym, so I always remind people that if you say it like smooth jazz, DBHIDS, it rolls off the tongue, right? Our mayor, he convened a task force to combat the opioid epidemic. It was pretty clear in Philadelphia, as you heard mentioned earlier. So in 2015, there were over 700 overdose deaths. In 2016, it was over 900 overdose deaths, and you heard the exact number of 1,217 overdose deaths in 2017. It was a really, I think, diverse group of stakeholders who came together that was made up the task force, and there were kind of 4 overarching strategies with 18 recommendations, and 4 strategies were prevention and education, treatment, overdose prevention, and criminal justice involvement. We're really fortunate that I think here in Philadelphia, my department actually it's interesting in that, so we have mental health, substance use, and then we actually also have community behavioral health, which is serves as a behavioral health managed care organization, essentially a health plan for people who are insured by Medicaid, kind of all under one roof. And so it created an opportunity for us to address issues in a little bit more of a coordinated way. We focus primarily on the treatment strategy and with the goals, with the recommendations being around increasing the provision of medication-assisted treatment, expanding treatment access and capacity, implementing warm handoffs, as you heard some of the other panelists talk about, and then providing safe housing, recovery, and vocational supports. And it ends up being a critical piece. So Philadelphia, as you all know, for a city of over 1 million people, has among the deepest poverty. And so what we were finding at different times is, even as we conducted the assessments and people made decisions to participate in medication-assisted treatment, they were still experiencing housing insecurity, homelessness, and so without addressing some of those issues, the fact that they were participating in treatment actually was really not getting the outcomes that we were looking for. We did a lot of work with various partners, the health department. We also did a lot of work with the state. Some of that was really around looking at, there was some requirements around seeking authorization for buprenorphine before people were able to participate, and so we were able to get some changes around that. Another major issue that we saw was that a number of folks didn't have identification, and so as you know, as they were approaching any of the opioid treatment programs without having that ID, that was a challenge, and so we came up with some really innovative strategies to address that. We are also, I think, really fortunate in that, again, because we, as a department, we really serve as a single payer, right? And so I often joke that Bernie Sanders would be pretty excited because we're pretty close to a single payer system. You guys would agree, right? What we also saw was when we looked at, we did some work on, again, really, as I talked about, just expanding efforts to increase access to medication-assisted treatment. We are fortunate in that we have a very broad, I think, provider network that's all the way from kind of outpatient to inpatient, both on the substance use and the mental health side. And so we more recently, just to share a little bit of data in terms of as we kind of pulled all these together and kind of pushed it out, we saw that we did a third quarter comparison on the number of people participating in any of the types of medications for MAT. And so what we saw was if a quarter three comparisons against fiscal year 2015, 2016, 2017, and 2018, as we saw a 36% increase in the number of people participating in medication-assisted treatment. We did a similar look against those same quarters, again, the third quarter of 2015, 16, 17, and 18, just for buprenorphine, and we saw an 83% increase in the number of people participating in treatment. Part of what happened is, in terms of broader strategies, and you'll hear some of this elaborated on later, is our provider network. We had one provider in particular, Regan Kelly, you'll hear talk about. They created Access Point, which is a 24-hour, 7-day-a-week program where you walk in and you can get an assessment for substance use disorder, and also can be induced with buprenorphine. We did similar kind of work with the hospital system, with some of our hospitals, the ED. We also have in Philadelphia crisis response centers, again, where the inductions are happening in some and not all. And we made a really concerted effort, as you heard, again, one of the other panelists speak to, of really working and partnering with people with lived experience. And so we actually have what we refer to as the Rose Recovery Overdose Survivor Engagement Project, where we have certified recovery specialists that are placed in some of our EDs, some of our crisis response centers, and when individuals show and their overdose has been reversed with Narcan, they're there to make a connection with that individual, talk about what treatment options are possible, and then actually kind of do, if you will, kind of a warm handoff. There has also been a lot of effort made around recognizing that once we get people, they make the decision to participate in MAT, we actually get them connected, if you will, with housing, and part of the effort has also been we really try to expand the number of both kind of recovery house beds and low barrier beds. And what I'll say finally is the last piece that we've also started to try to do is really make a concerted effort in working with providers on the vocational piece. And so what we recognize is that in order for the MAT, for the treatment piece to be sustained, that there needs to be that connection with kind of vocation. And so we, for example, contracted with an agency called First Steps Staffing. They have a history of working with people in recovery, and they actually have done a really nice job of connecting a number of people with full-time employment. And so that's just a little bit about kind of some of the work that's happened here in Philadelphia. We continue to be, again, appreciative of various opportunities, and I'll actually stop there because I believe I think we need to open up for questions.
Sure, thank you. It's pretty amazing, all these efforts across the country. So Commissioner Ingham, can you walk us through how you brought expanded access to naloxone across your county? What steps did you go through and actually get the buy-in from the people in your county?
So it is 98% funded by private dollars. And so the question became, once we saw how bad the number of people were dying in 2017 to opioid overdoses, is what would happen if we saturated the community with naloxone, in this case Narcan, using data to guide where we need to go at no cost. So there was a partnership between Brightview Health, the University of Cincinnati College of Medicine, Hamilton County Public Health, the Hamilton County Heroin Coalition, and Adapt Pharma, the makers of Narcan. And we came together and put a demonstration / research project together, which is now it's in its second year. And we said if we use the data to put this out, what would happen? Comparing 8 months of 2017 to the 8 months of 2018. So Adapt Pharma donated 25,000 doses of Narcan to us. And the College of Medicine at University of Cincinnati is the evaluation team. We're the logistical team. We're actually the boots on the ground in Hamilton County Public Health. We're the ones that are doing the distribution. And I might also add that every healthcare system in town, we have 5 major healthcare systems in greater Cincinnati, all contributed monies out of their either their community benefit dollars or their foundations to help us hire the people necessary to distribute it. So we obviously operate it follows a harm reduction model. It's a public health program. Obviously, we're doing syringe exchange. It's a comprehensive program, HIV testing, hepatitis testing, and also getting people into treatment. And of course, we're distributing Narcan there. We're also working with the hospitals to change, especially since the EDs in our area are the portal of entries into the system. Most people, EMS finds somebody, they overdose. We have all our first responders, our law enforcement, our EMS workers are all carrying Narcan. They're doing a great job. And people are transported into the healthcare system. The problem we've been having is that they're being putting back out on the street without obviously the reversible drug, the anti-opioid reversible drug, naloxone. And so we've been trying to, have them change their protocols, and that's starting to happen. The other thing that we've been doing, and every time along this way, we've been teaching about medication-assisted treatment. So it's our opportunity to teach and to change the systems in our town, in our community, and it's a cultural change. It's how a lot of providers in our community, since the systems are disconnected, don't see this and don't understand what is the best practices and so forth to help prevent people from further taking opioids and help stop the craving. The other thing is we actually set up at the jail. And so on Saturdays, when most people are being discharged from the Justice Center in Hamilton County, We have a big Narcan display there, and we also give that opportunity to teach them about if you're ready for treatment, we actually have instant access for you. And so it's a journey, and there's a lot of education involved and a lot of patience.
Thank you. Ms. Kaplan-Dobbs, can you tell us about expanding MAT into the primary care settings? Because we know this does expand access to so many people when they can visit their primary care physicians.
Yeah, indeed. So, so we know buprenorphine has been, traditionally underutilized. So the idea of doing it in primary care was really both to integrate it and destigmatize it. All of the work we do is really through the lens of destigmatization of MAT. We know that people often have trusting relationships with their primary care providers, with the clinical staff there. So we wanted to have a low threshold, another intersection point for people who may not otherwise find their way into a specialty drug treatment setting. So it was really about like destigmatization and integration. We have a pretty substantial methadone system in New York City, which is why a lot of our efforts recently have been about expanding access in buprenorphine. So we're doing it with these two larger scale initiatives, the Training and Technical Assistance Initiative, again, where we're training new buprenorphine prescribers across the city and really helping them integrate it into their practice, and working with both just the individual providers, but larger health systems in general, right? So I think in a larger setting, it's hard for individual prescribers to take this on. So when there's the support from the administration and leadership, as well as the individual providers, it really facilitates the process. And our buprenorphine nurse care manager initiative, so this was a model that was developed in Massachusetts about 10 years ago, and is now being sort of seen throughout the country, where an RN level nurse care manager, so we're funding 26 primary care safety net clinics. These are mostly federally qualified health centers in the city, and they're sort of spread out throughout the city to do this. And this RN level nurse care manager is working with the new buprenorphine prescribers to really support them. We know that primary care providers have a lot to do, right? And often have limited time. So having a nurse care manager there to really facilitate the patient process, I think, has been a big win for everybody. And the providers really like it, the patients really like it, the clinic staff really likes it.
It's great for expansion.
Yeah.
Dr. Hulsey, can you talk to us, you talked a lot about data. Can you talk to us about how you used the data to identify communities where treatment is needed, and then actually had the communities recognize that they needed that treatment access opened?
Sure. So I mentioned that the Department of Human Services has a lot of things under its roof: aging, child welfare, homeless services, and behavioral health. It also has a pretty unique resource in that it is a data warehouse. So all of those services, all of the records at the individual client level are integrated. So, and we also have, for some of our other county offices working with our health department and also our medical examiner, we have all the toxicology reports and all the autopsy results from the medical examiner. So we actually started with, similar to the other cities here, unfortunately, 2017 was a pretty, unfortunately, spectacular year for overdose deaths in our community, and all the years leading up to it. So we took all the fatalities for about an 8-year period, and we said, if we're going to do some planning and do some intervention and we have limited resources to intervene, how could we get the best bang for the buck? And where could we make interventions where most people may have been encountered? So using our integrated data, we started with a cohort of people who died of overdose deaths, and we started to see where did they present first. And some of the major findings we had was they were leaving jail. They were in our community mental health treatment, and also in substance use disorder treatment. But to dispel some of the myths that we have, everyone thinks, just go to rehab, get a few weeks and you're all good. You all in Philadelphia know quite well that that's not usually the case. If we have a recovery orientation or an evidence-based approach, you want to continue with your outpatient and stay engaged long enough in treatment for it to be effective for some of the things that you had mentioned in your opening statements. So what did we do there? We just saw some of the treatment levels that people had experienced were more frequently visited or encountered by individuals who had subsequently died. Many of the people who left jail were dying in the first weeks after leaving jail and up to the first few months. So we also did some spatial analysis to understand just simple frequencies or where those densities were in which communities were affected, either city neighborhoods or we have 130 municipalities in the county of Allegheny. You have 1 municipality, so it's a little bit of a different governmental arrangement. But we were able, working with our health department, also doing naloxone distribution and flooding those areas, also working with a harm reduction organization. We have Prevention Point Philadelphia, we have Prevention Point Pittsburgh, to kind of access hard to reach, people who might not be encountered in healthcare, but who are otherwise at risk. So really flooding the community with naloxone as well. It also, I think, helped to provide a foundation for our jail to consider upon the people prior to release, similar to that. We're not set up, but we're working with the health staff. So people who, prior to release, if they want it, they can get naloxone in a bag before they leave. So that's some of the prevention work that we had done. Some of those neighborhoods were targeted by public health strategies. We also convened with an organization, the surrounding municipalities and those who are disproportionately affected, to talk about this issue, develop a health subcommittee, and develop an emergency response plan for some of the first responders. A lot of them are contracted rather than sort of city or municipality based. And I think it has also helped, the data that we've provided, it's also helped to consider medication-assisted treatment approaches, of course, starting with naltrexone, injectable naltrexone in the jail. That's one I think many people are comfortable with, although we don't have the evidence that we do for buprenorphine and methadone maintenance. But that's a plus. That's moving along the continuum. Another thing that was very surprising, about 1 in 20 residents in the county encounters our publicly funded mental health system. What we found in our research, a lot of people had encountered our mental health system. That might be just an assessment, but they might have been in long-term treatment for a severe mental illness. And there was no overdose prevention. In Pennsylvania, it's a little bit hard, given the regulatory framework, to do good co-occurring integrated care. But that provided a platform to start dialoguing with our mental health providers and to develop overdose prevention protocols, consider medication-assisted treatment, and recognize that a lot of people who had died who were Medicaid members had filled prescriptions for not only opioids, we see some of that, but for psychotherapeutic medications. So it's a real testament to the fact that people are struggling with co-occurring mental illness, and if we just keep talking about substance use treatment, it's very difficult to deliver treatment for those conditions in our specialty substance use treatment in Pennsylvania. So
it's a great way to partner and use the data to expand into all the communities in the county. So Commissioner Jones, you recently announced that Philadelphia will have 100% of MAT availability in all residential treatment programs under contract with the city by January 2020. Can you tell us about this exciting plan?
Sure. So we continue to recognize that there are several pathways to recovery, and choice, always plays a role in that. We, as the evidence has been overwhelming in that we recognize that people with opioid use disorder really benefit from, again, medication-assisted treatment that has been emphasized several times. And so while we currently have about 65% of our residential treatment providers that are prescribing or able to prescribe MAT, the goal is to get the remaining 35% also prescribing, again, recognizing that when folks have access to MAT, it generates the best outcomes. We are recognizing also that we've worked with this provider, that provider network, to say we are going to do both kind of a stick and carrot approach as well. So it's a little bit of we will increase your rates and recognize that that's a kind of a part of the equation, and to the extent that you really feel like you don't want to make MAT available, then it's probably not good that you continue in a network. So it's kind of, and so we feel like it's the right approach, and we feel like we have given, ample time to make the adjustment. I think at this point we actually have not heard much pushback, and we think it's in fact the direction to go.
Great. So all of you have talked about partnerships, and I'm curious to know, are there some partnerships that you feel were definitely, I will call the usual suspects that you would partner with, but then are there other ones that people might be surprised that became an important partner in increasing access to MAT? Commissioner Jones?
Well, so we actually, there's one, I think, really kind of out-of-the-box partner that we've worked with here in Philadelphia. So the Mural Arts Program, so it's a program where the arts work with the community, and they go into communities, and particularly where there have been situations where there have been maybe issues around suicide, or there have been some other kind of behavioral health challenges. And the Mural Arts Program will go into that community. They're partnering with us using, in a number of instances, certified peers, so whether it's certified peer specialist, certified recovery specialist, and then give information about the behavioral health system. And so what we found is that in certain communities, particularly communities that have been disproportionately impacted by the opioid epidemic, that when we have set up kind of storefronts in those communities, the opportunity for those community members to come in, there is, I think, the relationship, there's trust there, and so they've come in, and it's also a way that we've been able to address, as was mentioned earlier, kind of the stigma around approaching and participating in behavioral health treatment. And so that partnership has really generated some pretty good results in terms of having more people come in through a very non-traditional portal, but then get connected to some of the treatment services and supports that they need.
Oh, thank you. We'd love to hear from our other panelists about some unusual partnerships.
Well, I'm not sure if they're unusual. I look at it as, of course, it's all about finding the champions in the right places at the right times, the people that can make change, that believe that they should change the culture of a system or so forth. So I look to the physicians. There are physicians in our communities that are championing this, and that ultimately is what, with all the competing priorities that there are inside, that we all deal with every day, but inside the healthcare systems, it's all about making sure that that gets on the chief clinical officer's agendas. And that I've also found that it's best if it comes from the front line. So the folks that are seeing these individuals come to them through the emergency departments, those physicians and nurses and so forth, they can get the message up that we've got to do something. And there's we know the best evidence out there. We know medication-assisted treatment works. We also know we can't let anybody go back out on the street without a dose of naloxone or Narcan in their hands or in their family member's hand, because it's just the right thing to do. So I look for the champions in the community, not only in the healthcare system, but also, of course, in our legislative delegations too.
Dr. Halsey?
Well, I'd say not necessarily the role of within the health system in expanding medication-assisted treatment, but I would say a partner in this work that was surprising to me. I sit on the board of one of the largest recovery community organizations in our region, in our city for sure, and there's a very strong 12-step community in Pittsburgh and the surrounding area. And some of the narratives among that community was not accepting that using medication-assisted treatment can be part of a recovery, and that goes into the stigma. But it may also just not having access to the most up-to-date information, because maybe in times past that may have been true. But then this past year, I was pleasantly surprised, and I didn't even know about it until it was already up and running, is that there were medication-assisted treatment recovery support groups. So that this facility hosts meetings, NA, AA, those kinds of things. And now medication-assisted recovery is a part of the available recovery support resources in our community. So I think that's was a surprise, but really organically just emerged, likely because people are seeing the need, and we've been so hard hit with overdoses.
How about in New York City?
So I think that some of the stigma is rooted in the fact that substance use treatment has been very siloed from general medical training, right? So when we're looking at, when we're asking providers right now to start doing this, they're like, well, this wasn't something that I was ever taught in medical school. So we're doing a lot of work right now in health profession schools and medical schools, nursing schools, to work towards a curriculum change, and then also working with student groups so that hopefully the next, or what seems to be true, is that the next generation of providers are going to really see this as just part of their scope of practice, right? That this doesn't have to be something other, that this is just another chronic disease that we can treat in a general medical setting.
Interesting. So sometimes we hear that there's treatment slots available, but they're not being filled. So can you tell us a little bit about how we can address that and how you might be addressing that gap? Maybe Commissioner Jones, you can talk about how we're doing it in Philadelphia?
Yeah, so I think there are different perspectives on the available slots, right? I think first of all, what we know is that there are times where when people make that decision to participate in treatment, having that kind of treatment on demand that is really critical. And so I think that narrow window of when someone says, I'm ready to come in, I'm ready to participate in treatment, having that available slot at that time is critical. So I think there is, obviously significant benefit to having the available slots. I also think that there are times where the reason there is the perception that there are available slots is you see a shift from, maybe there were individuals historically that had preferred methadone, for example, over buprenorphine, but then now they're making a shift, and so you'll see slots. Certainly, I think that's the case here in Philadelphia. I mean, it may be similar in other places, but so we see sometimes a shift from methadone to buprenorphine, and so you have the available slots. I think the other the other challenge sometimes is, again, as was mentioned, it's just the stigma of, now I'm kind of substituting one addiction for another addiction, and so you have that. And I think finally the other piece that we see at different times is just that you still have apart certainly from the substance use disorder kind of community of taking a medication-free route, and so that the idea of MAT, although again to me it's contrary to the science, you still have to respect that kind of difference. And so I think that those are reasons at times where you may have kind of slot availability, if you will.
I was just going to say that I think that there is still so much stigmatization in our society about opioid use disorder. People are still seeing in parts of Ohio as well, and a lot of the country, we have a lot of work to do as a moral failing, which we know it's not. We know that this is a disorder, it's a disease, and as we understand it better, we know the progression. So I think that some people are just have not been treated well by our healthcare systems. They haven't been treated well by the people that we expect them to hold up the best care forever. When we walk into our healthcare systems, and we do have great healthcare systems, but in this situation, there's been clearly some work needs to be done. So I think people want to know how they're going to be treated. I also think that there's not patient reminders. I mean, one says, how far do you go? How far do you go to make sure people, well, we know most of us in this room are fortunate enough maybe to have some commercial insurance, and pretty much my primary care doc and my dentist and everybody else, I get patient reminders. And so I'm not sure why we're not perhaps doing that in that area. There's obviously transportation issues, but those can be solved. But I really think it fundamentally comes down to that there's a stigma, they're scared, and sometimes people just don't want to go into it, and it's a big decision.
I think there might be kind of two dimensions of this. I mean, certainly there's all the practical, the transportation, and you have a dog or children. You might need to manage that if you're going to go into at least residential treatment. But part of that is really communications as kind of a lack of understanding about what is treatment, what is effective, what is good treatment, what should you expect, what does recovery look like, how do you start treatment, if you are you insured, what if you're uninsured, how do you get the treatment? I think all of those issues, it's not common knowledge, and there really aren't good resources for that. We have PA Get Help now, which is a 1-800 hotline, which is a great resource. But historically, we haven't had that, and I don't know that that's just common knowledge. So I think part of it is just this understanding and demystifying what it means and what to expect. And secondly, I'm really glad you had presented it as treatment slots. A lot of times when we have discussions on this topic, people want beds, or beds and slots are interchangeable. And there is a historical, there is people who advocate for you need residential, you need a bed. But especially with these newer modalities, certainly there aren't other kind of co-occurring issues, and if it's primarily opioids, these are very successfully and effectively treated on an outpatient basis. But I don't know that that message has translated, so that may be one of the factors.
Yeah, indeed, I'll echo what some of the other panelists said, that there's this misperception that everybody needs to go away to detox and be somewhere far away, when in fact, and certainly some people do need residential treatment, but many people can be successfully treated outpatient in primary care as well. I also think that we're in New York City, we are moving away from the term medication-assisted treatment to MAT, meaning medication for addiction treatment. That the medication is the effective treatment with or without psychosocial counseling, right? That the data show that people do just as well with or without psychosocial for their opioid use disorder, right? People certainly have, many people certainly have other co-occurring disorders that need treatment, but people do just as well on medication alone as they do with psychosocial counseling. So the idea that this can be very easily done in primary care for many people, that's the messaging that I think that we're working on also to destigmatize it.
All of you mentioned data as one of the key drivers to bringing all of this into your communities and making people listen, which is so important. Can you share with everyone some of the key data points if you're new to this or you really want to make a change in your community? What data pieces should you be looking at, and which ones should you make sure you're collecting? Commissioner Jones?
Well, so part of, so for us, particularly as we look at, again, the number of people that are participating in medication-assisted treatment, and as some of what I shared, we tend to look at both the rate and the number of people that are participating. And so we certainly expect that those numbers will continue to grow. And so that is certainly a critical piece. The other piece that, again, that we mentioned in terms of is really around, at this point, naloxone training and distribution. So we have, in partnership with the health department and other stakeholders, there have been, easily over, 3,000 people trained and probably nearly 75,000 doses of naloxone distributed going back to the beginning of calendar year 18. And so, as was mentioned, I mean, at the end of the day, really what this is about is saving lives. And so we want to make sure that we have people alive long enough to then make the decision to participate in treatment. So I think that those are certainly some of the data points that we look at.
Yeah, and I'll say that, we certainly, New York City has a very robust surveillance system. So I think that one of the things that has really benefited us is being able to see, who in the city was dying, where they were living, where they were accessing their different services, to really be able to see which communities we needed to best serve. So I think that is a key thing. And then we're seeing, in our nurse care manager initiative, most of the patients that have come through are Black and Latinx and are almost entirely Medicaid beneficiaries. Same thing with the providers who have come through our training and technical assistance initiative. They're reporting to us that the majority of their patients are Medicaid beneficiaries. So that sort of helps us know that we're getting to the right people. The poorest New Yorkers are the ones who are most affected by this crisis right now. When we're looking at what is successful, I think one of the biggest indicators is really going to be treatment retention, right? Because if somebody is still in treatment, they are still alive or still, engaging with their provider.
I could probably talk data stuff until I see every last pair of eyes close and still be excited. But I would say, but I'll just keep it to one main point, and I sort of agree with the last thing that you said. Of the number of people who are receiving publicly funded treatment, at least the records which we have access to, of the people who are receiving treatment, how many are exposed to a medication or not, if you're starting from the specialty substance use treatment. We just completed some research where we found that it's probably improved a little bit since then, but 46% of the people who presented to substance use treatment with an opioid use disorder get exposed to a medication with a very liberal definition of what constituted as medication-assisted treatment. And that's improved from 39% a few years prior. So it's certainly improving, and the size of the treatment population has grown, with Medicaid expansion, it really, really expanded in the midst of an opioid epidemic as well. But I'd say that that's key, but also treatment engagement. We captured those numbers, so we looked at that proportion, and then we compared people who did and did not get exposed to these medications, and did they stay long enough in treatment for it to be effective. For outpatient treatment, that's considered by the National Institute of Drug Abuse and SAMHSA, the Substance Abuse Mental Health Service Administration, as 90 days for outpatient. There's 30 years ago, there was studies done, and everyone still holds those to be true. And for methadone maintenance, it's 1 year. And we compared people who were similar to one another with their past mental health severity, their current substance use severity, age, legal sex, race, and watched their treatment episode begin. And what we found is you have more than 2 times the odds of reaching an effective dosage if you use a medication to support your counseling treatment. That's not novel, but we replicated that for our region and hopefully to use that for policy development and decisions in the treatment system. But how long are people staying in treatment and whether or not they're exposed to a medication.
Excellent, thank you.
Well, I'm going to kind of repeat the obvious here. So the ultimate harm here in our society is what I call the tip of the public health pyramid or iceberg, and that is the number of deaths. The ultimate harm is when we lose these productive lives, and we all know that data. And so the other thing is, we watch through Epicenter and other surveillance systems that have been put in place in public health over time, the number of emergency department visits for people presenting with chief symptoms of overdose, and the number of 911 dispatches. And I'll just simply say that I started to talk a little bit about the Narcan Distribution Collaborative Project, and we have seen, looking at 8 months of 2017 with 8 months of 2018, we have seen a significant reduction. And we know the Narcan saturating the communities has been a part of that, a big part of that, but it's also been opening up access, treatment on demand, and the other thing is better integration between the behavioral health system and the healthcare system. Are the three factors that we feel are starting to contribute. We saw a 30% reduction in overdose deaths due to opioids between those 2 time periods, and a 40% reduction in EMS runs. Now, it's not just the naloxone project. It would be unfair of me to say that. It is in combination of the others. I would say to you that we can tell when people are sometimes going into treatment, especially through the public insurance programs, through Medicaid and so forth, but what we don't know is if they're completing treatment. And the other thing is there's still a disconnect in data between our healthcare medical records, electronic health records, and our mental health system. And I realize there's a lot of protection, and we're very sensitive to it, confidentiality as we should. But there are public health reasons that those two should be a little bit more unified. And so if you're a physician and you have a patient that's suffering from opioid use disorder that you've been seeing for years, I'm sure that when you do that referral, you would like to make sure that the behavioral health system, you're getting data back and forth so that we get a complete picture.
Excellent.
More work to do there.
More work is right. I'd like to open it up to the audience to see what kinds of questions you have for our panelists. I think someone has a mic. Okay, great. We'll start with the person in the back since you're back there. If you could tell us who you are, where you're from, and then the question for our panelists. Thank you.
Sure. Hi, I'm Mike Dahl. I'm with a local organization called Broad Street Ministry. We serve vulnerable populations with meals and services. One thing I didn't hear anybody talk about was resources, money, dollars. There are wonderful programs going on in Philadelphia. We benefit from them every day, but we're still a long way away from true treatment on demand, from having enough quality seats, from having places for people to go when they come out for supportive housing. What's the answer as far as, are we going to need more state resources? Are we going to need more federal resources? Because clearly the scope of the intervention is a critical aspect of expansion. So what is being done to just generate more resources, more attention, translating into better programs?
Would you like to start?
So certainly, so I'll start. I think that, obviously it's a great question. I think the issue around resources, so part of what we continue to do is we, we do benefit and want to acknowledge that, so for Philadelphia City at 1.5 million, what we're continuing to see is the number of people through the Affordable Care Act and Medicaid expansion, we're continuing to see the number of people who are eligible actually begin to participate in treatment. So through that opportunity, we actually are seeing more resources coming in terms of, again, through community behavioral health and Medicaid eligibility. So I think there's a benefit there. Where we saw, I think, some funding coming in that was really, kind of making a difference in terms of people on the street that is potentially about to shift is around general assistance. And you'll know that 200 bucks that folks were getting that looks like is about to potentially shift, that was making a huge difference. And so, we continue to want to see that happen. Additionally, I think that, there's always conversations that we want to have with both our state and federal partners, to me, around additional housing resources. We mentioned just in terms of whether we're talking about recovery housing or low barrier housing, that's also a critical piece. I think that, we continue to try to advocate, but I think that's about kind of the state of affairs now in terms of what we're trying to do to generate more and more resources.
Anyone else like to add to the resources?
There's never enough resources in public health. We do what we best using data to prioritize where we need to be. I would only say to you is that there are opportunities out there to leverage perhaps private dollars with public dollars. When you can find a foundation or a private corporation who's willing to put some money into a project when they know that you have some skin in the game too, through your own public dollars, it's amazing how much money you can attract. This problem is so pervasive, we all know it has touched every life in this room. We all know somebody in our circle of family and friends who's suffered or has passed away because of opioid use disorder. It's pervasive.
I mean, so New York has a pretty robust Medicaid program that pays for a lot of services, and services that aren't paid for through Medicaid, the city health department pays for a lot of them. But there are some key points that we would really like to see Medicaid paying for in the future, specifically this care coordination piece, where there's no way, at least in New York State, to bill for care coordination for substance use disorders, which is a really big leverage point. Like we see how useful it is and how well regarded it is both by the providers and the patients. So there's that. There's also, there's no payment assistance there's no federal or state payment assistance program for buprenorphine like there is for some other medications for chronic health conditions. It's a very expensive medication if you do not have insurance, or if you're underinsured, if you're a pharmacy benefit, if you have like large copays for it. So that's something that I think really needs a lot of attention to actually like pay for the medication. You can have a subsidized provider and FQHCs that like allow patients to come in and work on a sliding scale, but if there's no way to pay for the medication, particularly for people who are coming out of jails. In New York City, we have Rikers Island has a buprenorphine methadone program people often leave with a connection to care and a buprenorphine prescription, but if their Medicaid gets suspended while they're incarcerated, and when there's this lag time between when their Medicaid gets turned back on, that they actually necessarily don't have the funds to pay for the medication. And when somebody is released from jail, like we know that one of the other panelists was saying that their risks of overdose are extremely high. And this is like really a critical population that we want to be able to capture and be able to provide services to in the most comprehensive way that we can.
So should we take another question? How about we move to the front of the room now?
Thank you. My name is Christina Doherty. I'm a licensed clinical social worker, and I have founded and run a program or a private psychotherapy practice and substance abuse practice in in Philadelphia. I've worked in dual diagnosis and substance abuse all of my career. I ran a dual diagnosis treatment program at the Tampa VA hospital, which actually was one of the first organizations in the VA system that rolled out buprenorphine a couple of years ago, and we had really good results from that. So I know about medication-assisted treatment, and I was really glad to hear that about the 12-step community and how they're reducing the stigma about medication-assisted treatment. But one thing that I found in Philadelphia from the recipients of the treatment that I work with, I have a network of primary care doctors and other providers, psychiatrists that do buprenorphine and Vivitrol and things like that. And the things that I get from my patients is that that's not necessarily true here in Philadelphia. And so to address the stigma is that I believe, and I think that it's important for people to know that medication-assisted treatment is part of an abstinence-based treatment and can be part of the 12-step community and still be in recovery. So I'm wondering, what we're doing for people in primary care that are giving buprenorphine and or Vivitrol or whatever, and are they encouraging them to do some type of cognitive-based counseling, outpatient treatment? Because I know that the quality of life for these patients, as well as the quality of life of the family members and loved ones, are better and improved, and adherence to treatment when they are doing some sort of 12-step program or psychotherapy or dual diagnosis treatment, because 50% of people with substance use disorders also have a comorbid psychiatric disorder and need to be managed in some type of outpatient care. So that is one question. And then the other question I have for the commissioner, community-based, the organization that manages Medicare for Philadelphia County, CBH, I have tried to get a Medicare contract, and since my organization is smaller, I have not been able to be successfully able to get a contract. I know that some of the Medicaid facilities that do outpatient treatment don't provide some of the quality care that we need for comorbid psychiatric disordered patients, and also tying in with the community with the abstinence-based treatment. And so I'm wondering what, I know other counties that contract with Magellan, Medicaid and Magellan do contract with individual providers and small private practices, and I'm wondering if there's any initiative to move to where we can get more of these quality, smaller base practitioners to be able to take Medicaid in this county. So thank you.
Sure. So I think that I'll start with your first point, which is it's actually great to hear that that there's more receptivity in terms of that MAT being a part of the kind of recovery process, and some of those more kind of historic kind of abstinence only kind of groups. And so I think the more that we can get the people more receptive in terms of expanding the broadness, if you will, of the definition of how people who are participating in MAT, that's also those folks are able to be a part of the provider community that have, again, historically taken a medication-free route. I think that that's great, and I think we want to see more and more of that happen. Again, because we recognize the role that choice plays. And then in terms of more specifically around contracting with community behavioral health. So generally speaking, what we do in terms of kind of a transparent process is we issue kind of broader procurements, and it's an opportunity for providers to come into the network that way. I think that, and that'll continue to be the process, and certainly that'll happen probably in over the next 3 to 6 months again, where there's opportunity to enter that way. We also at different times, because of again how we're structured, for some of those individuals who are uninsured, through kind of our division of behavioral health, there's opportunities to the contract that way. And so what I will say is you can certainly be in touch with me, and I can put you in touch with some of the people in our department that can help facilitate that process.
And Dr. Halsey, can you expand?
Yeah, I would say what you're describing is actually maybe not uncommon in the Commonwealth, in that in Allegheny County, our Medicaid program, we have, as you know, OMSAS and DDAP, the license provider agencies, individual practitioners, psychologists and psychiatrists, they have their own boards or whatever licensing bodies. And our insurer in our county contracts with agencies on the substance use side and agencies on the mental health side. Individual psychiatrists and psychologists are contracted for primary mental disorder and not substance use disorder. While you may have major depression and a co-occurring substance use disorder, I don't think those licensing bodies, because you're not licensed by them, at least if you're not licensed as an agency, they wouldn't be, program monitoring, and coming into your office. Maybe other payers and other agencies, regulatory bodies would. So I think what the commissioner said is, it's accurate, but it's not unique here. I'm just saying. The second part about needing counseling, I think we're at a point where the science is, there's a lot more evidence, but I don't think that we really have an understanding of the individual case and needs, so the psychosocial needs. So if you have transportation, you have adequate financial resources, you have family and friends in your life who can support you, you have a job, you have like all these other resilience factors, and you just have an opioid problem, you don't drink, you don't use other kind of, medications in a harmful, unhealthy way, outpatient-based medication only may be appropriate. Then you have that discussion on what your recovery or treatment path will be, what your goals are, and discuss that with your health professional and make that decision. But to monolithically, say across the board, we always have to have counseling. I usually say that because we're talking about our behavioral health system. So if we offer counseling, we always want to offer medicine to support that. But that's, just getting Suboxone is not MAT. I mean, that is medication management. It's treatment with medications, and it can be very effective for some people. For whom that would benefit, or you see people with criminal justice backgrounds in the jails because there's marketing to tell them that injectable naltrexone is the best way to go. Well, we don't have the evidence to suggest that that's the case too, but it's not narcotic, it's very appealing, but that may not be what the science says and what might best help someone who may become more at risk of overdose within the month when that wears out, in their body. So I don't know that, and I could be incorrect, there may be others who disagree, and that's fine. But I'm not aware of research that really tells us you can go through a matrix and say, checkbox, checkbox, this is what's appropriate for you. But I think it's a complex picture on what that individual's needs are and what their life looks like and what their medical condition presents as.
And I'll just respond and say, we certainly see the benefit of mutual support programs like 12-Step or Refuge Recovery. I don't think, and what we've seen across is that this can't be a requirement for people, right? Like, we want medication access to be as low threshold as possible. So if somebody does not want to go to 12-Step, saying that they have to in order to receive buprenorphine treatment, I think is not the public health model at all. We are, though, as this was said, I think that we are seeing sort of the tide changing a little bit in the mutual support communities. And I think also it has to do with the education, right? So like we hear this trope about like, you're just replacing one drug with another. When we sort of talk about the difference between addiction and dependence, right? Like in the chaos of addiction and then being physically dependent on a substance like coffee, like some of us. You know, it's like it's a different thing to think about, and it's a different way to talk about it. And like once you sort of bring that up with people, it's like, oh, that's like actually really clear, right? I can use insulin every day, and like, yes, I'm dependent on it to keep my blood sugar stable, but I'm not addicted to it, right? So I think well, when we start using that language and start talking about that community-wide, I think that shifts things, and that allows like more people to have mutual support programs if they want it.
Another
That was
question?
Yeah, that was really well put.
Thank you. Hi, my name is Gail Scott. I'm from the University of the Sciences here in Philadelphia, and thank you very much for this, all this information. I've been involved in policy, particularly for buprenorphine, since 2005. Prior to my switching careers in academia, I worked for the manufacturer of buprenorphine, so I worked with physicians and helped launch that for 7 years. So I'm really interested in this policy question, and I want to ask, as a researcher now, I know one of the data challenges is that it's hard to track how many people are on medication in treatment facilities and in private practice. We don't have good data on how many, we don't have good data available to public and to the researchers about how many people are getting treatment from the private practice, the OBOT model, the office-based physicians. The manufacturer has that information,
Right.
but the researchers don't, so that's challenging to me now being on the other side. And we also don't have good data on how many people are in the treatment facilities who are getting buprenorphine or methadone from another source. So we don't have a good way to track when they're getting treatment from Gadenzia, for example, but they're also getting buprenorphine from a private practice person. So because in Pennsylvania at least, and this may not be true in some other states, but in Pennsylvania the licensing only looks at the capacity if they're getting it delivered from the treatment facility they're in. You follow me? So I'm really interested in, from a policy perspective, in your thoughts about maybe how we could change that and better track it, and also how we could facilitate it, because one of the problems is, it's awesome that Philadelphia is now moving forward with the carrot and the stick approach to try to mandate some of this, because that has to happen. And we've protected abstinence-based facilities for a long time that refused to allow clients coming into their treatment programs to have medication. They refused to. So now you're saying we're going to, require this to some extent, which is great. I think requiring any form of MAT means that most of those facilities that have refused to accept clients on buprenorphine or methadone are going to say, great, we're MAT now, we're only going to allow naltrexone. So my concern is about that. What ways can we protect whether they're refusing to accept clients on methadone or buprenorphine? Less than 5% of residential programs nationwide allow somebody to come in on buprenorphine or methadone, less than 5%. And I think that's true in Pennsylvania, but I know it's true nationwide. So one, how do we know? And two, how do we stop them from prohibiting clients from coming in on buprenorphine or methadone? Because they may need still residential treatment, and they certainly may want counseling while they're in maintenance treatment. And there's such resistance and stigma in the treatment community against maintenance treatment, as you know.
Yeah. So go ahead.
Well, the first part of that is like the mandating. I mean, that's really not the spirit that we let, that what we say in our position statement, maybe different philosophical approaches to this, but what we want to understand is that every provider has the capacity to do so, even referring out to a prescribing physician, and that they make it a mandatory, like what we want is that every patient with an opioid use disorder is educated about what treatment options are available to them, rather than you must, right? For the patient level, the provider must have the capability. And we state that in our position statement, and if you're interested in the wording, we can provide a link in communication with the audience. The second thing is that something very special happened a couple of years ago in Pennsylvania, asking about the availability of data, whether it's the specialty treatment provider or the prescriber who are at separate locations, separate licenses. We actually have that, and David Kelly, the director of the Office of Medical Assistance Program, has been a long-time leader and was successful. So all of our BIMCOs, our behavioral health managed care organizations, and our physical health managed care organizations for our Health Choices program, our Medicaid managed care, have all received the claims for the respective sides of the Medicaid claims. So the behavioral health MCOs have the physical health claims and vice versa, including pharmacy. So the research I had just described on looking at treatment engagement, getting an effective dosage, and whether or not you were exposed to a medication during your counseling treatment, that is what we use to explore to understand how we can better improve the quality of treatment for people seeking it. So we connected the pharmacy data. We could look at the physical health, kind of the healthcare perspective and the comorbid physical conditions, and we looked at the substance use claim in addition to the mental health claims. So that is very possible to do at the county level. You know, we have one way of doing that in Allegheny County, but the data is available. So it is available. How that is accessible to an individual researcher would be, you know, something to figure out.
Yeah, I'll say that. So in New York City, we look at the prescription drug monitoring program data. So we see, so we see both the number of prescriptions that are written, and then we see the prescriptions that are filled, right? And we see that de-identified. As far as like which medications are offered, it really becomes like who's the person, like what's the agency that's overseeing the contracts, right? Like where are you leveraging it, and like what are the possibilities of like, yes, you have to provide offer both agonist and antagonist treatment. You know, I think it becomes to like who's holding the contracts.
We only have a couple of minutes left, and I'd like to give each of our panelists an opportunity to give some last parting words of wisdom from the public health official perspective. So, Commissioner Ingram?
Words of wisdom. Don't give up. Never give up. I would say, though, I did want to talk about something that and the gentleman in the back asked about resources, which kind of spurred this, something that happened in our community. You know, there's always people out there wanting to help. There's no lack of people concerned about this public health issue. We had we have, as many towns, we have these incubators for, you know, that young minds come together to put a product together to try to solve a community problem, a public health problem, a social issue. And so we had that happen in Cincinnati, Hamilton County, where a young group of IT gurus, if you will, have created an app called findlocaltreatment.com. And, you know, if you think of the people that we use for phones for everything, you know, literally everything. And so it's an app that's put on a phone. It launched in May of 2018. They found some monies from some of the healthcare systems, and I think Scripps Howard put some money in it. It doesn't matter. But it's a community solution on trying to find real-time access to treatment. Because we know that it wasn't that too many years ago, it was 6 weeks to 6 months in Cincinnati to get a slot. Well, now, and it's about making sure that when you're ready to go, you can punch in and say what disorder you're suffering, what insurance you have or not, and a bunch of places will come up and say, we have a place for you now, within 24 hours. And it's really a great product. And it's probably one of our best kept secrets in our community. And I thought I'd go ahead and put it out there because it really should be looked at by all communities, because we know we have real problems with sometimes credible, if I might say, real-time access. And so that's something we're using, findlocaltreatment.com. I'm sure the guys that put this product together might be watching. They're saying, yeah. Well, I have no stake in it. So, you know, I just want to see people be able to, when they're ready to go into treatment, that they can get there, because sometimes, as we know, if they say they're ready today on Friday and we don't have a spot for them until Tuesday, it may be too late. So we're in this together. And this became a public health issue. Like I said, there's never enough money in public health. But when this became the leading cause of death for all the people under the age of 50, it replaced traffic fatalities in all our communities, that got my attention as health commissioner. And so we'll continue this journey of keeping people alive, preventing secondary infections until people are ready to go into treatment. thank you for having us here.
I don't know, I didn't prepare myself for that one, but as I was thinking about it, when you do all the important work and you continue doing the important work that you do in whatever role that you play, just consider the language between, I think that's important, the overdose prevention and the treatment perspective. What we've found is maybe about a quarter of the people in our town, at least the records that we have for publicly funded substance use treatment, about a quarter of the people had substance use treatment prior to their overdose death in the year prior. So there's a lot of people who are not encountering our substance use treatment system. They're hitting our mental health system, maybe not even hitting any health system, physical health or otherwise. So not to confuse keeping people alive in overdose prevention with treatment, because MAT would not be the primary strategy to keep people alive and to prevent an overdose, and it's an opportunity to engage. And then, secondly, I think all of us are living through a change in the philosophy about drugs, stigma. It doesn't feel like it, but I think we are living through a changing narrative, and the science is growing, and so just thinking about where we might be in 20 years and what we were each doing during the midst of this epidemic.
So two thoughts. One of them is just specifically about the primary care workforce and bringing buprenorphine treatment into part of the practice. I think that there are certainly providers who we've worked with who started off as ambivalent about it, right? Is this something that I can really actually do? Do I really want this? And there's one guy in particular who I'm thinking of, who is very much in this camp, and things have changed so radically in his perception just over the course of a year and a half. And we were in a meeting, and he's like, "This Suboxone is like a gift from God," right? So I think about that, but then I also really want to encourage everybody here to view this as from a harm reduction lens, and to remember that opioid use disorder, the pattern of the disease is relapse, right? Even people who are engaged in treatment, even people who are engaged in agonist treatment, right? That is part of the nature of the disease, that people sometimes relapse. But one of our nurse care managers brings up this analogy that in the 90s when we were treating, when the AIDS crisis was at the forefront of everybody's mind, and we were encouraging everyone to use condoms. And so you gave somebody condoms, and they came back, they're like, "Oh, you use condoms about half the time." You didn't take away their condoms. You were like, "That's great," right? So when we see a reduction in use, that is actually a huge win. And the idea that sometimes comes around to that if somebody is not perfectly adherent and perfectly abstinent from the illicit opioids that they were using means that they can't be in treatment at my setting or whatever. It's something that we're really trying to shift the perception on, right? So this is a harm reduction approach that we want to take in general, and the point is to keep people alive and keep them engaged in treatment.
Thank you.
So three very brief final points for me, and I feel always a little bit more of an obligation when we're here kind of in our own backyard to make some real practical connections. So just in terms of the PDMP question that you asked, I do want to, Dr. Suet Lim and Dr. Choa and Ham are here, and I would ask you to make connections so that we can talk about, again, more practically in terms of sharing the data to the point that, or at least, if not sharing, I don't want to, how to maybe access, I'll put it that way. Let me also say that we really believe that it's critically important to take services to the people. Part of what we've been talking about is, whether it's, kind of how services, whether they're coming through the FQHCs, whether they're coming through the EDs, the crisis response centers. One of the things that we've actually seen greater success with is we actually have had mobile medical vans, a couple of providers, and they really have been taking those services directly to the people. And I think both addressing some of the stigma and addressing some of the tri-occurring issues, the physical health, the mental health, and the substance use. And so I think we would like to see more of that, and I think that very much aligns with the whole idea of harm reduction. And then finally, I think part of what we also need to do is do kind of this work we are engaging in with the again, the health department on a public education campaign to make sure that the broader community who are supporting people with OUD and generally substance use disorder have an understanding of the benefits, for example, of medication-assisted treatment. We are scheduled to launch a public education campaign that'll probably go, be launched the middle of February, end of to the beginning of March, with the idea that BUPE works, right? And so if you guys can join in and saying that with me this one time, then I will know that we've been successful. So on 1, 2, 3, BUPE works. Thank you, guys.
That's good.
Thank you. And please join me in thanking our panelists today. We really appreciate your insight. Thank you. That's so good. Thank you so much. Thank you, Commissioner. Nice to meet you. That was great. Thank you so much. Thank you. I'm sorry. Oh, good. Thank you. I'm so glad. I think it went well. I think so. I'm glad there's. gentlemen, could you please take your seats? We're going to start the next panel. Can you please take your seats? Everybody, participants, our lovely audience, can we please take our seats for the next panel? Thank you. Thank you for those of you who are able to stay with us. We're very excited. We have our next panel that I'd like to introduce. So just like individuals with any other chronic conditions, patients who have opioid use disorder require a spectrum of medical and non-medical services. As we just heard, an evidence-based comprehensive approach to delivering on-demand treatment should include FDA-approved medications, behavioral health therapies, and other services to address factors such as housing that may affect a patient's long-term recovery. These services are provided in numerous settings in Philadelphia. Our next panelist represents 3 of those settings: a treatment center, a family medicine practice, and the emergency department. And while our panelists provide care in Philadelphia, we think their experiences are relevant in cities across the country. So please let me introduce our next set of panelists. First, we have Dr. Barclay, and he's a primary care provider with his own practice in Center City, Philadelphia. Regan Kelly is the president and CEO of Northeast Treatment Centers, also known as NET Centers. And Dr. Priya Maman is an emergency medicine physician who serves as the director of public health programs and clinical associate professor of emergency medicine at Sidney Kimmel Medical College at Thomas Jefferson University. So welcome. And I'd like to again extend the opportunity for you to tell us a little bit about yourselves and about your practice. Dr. Barclay?
So I've been asked to speak about my private practice and my treatment of opioid use disorder. I have a practice a few blocks from here on 16th and Walnut. Most of my patients there are professionals, they're business folks, lawyers, people who work in those big buildings next to my practice. And they're pretty much all privately insured and they have Medicare. At any given time, I treat probably 20-some folks with opioid use disorder. Pretty much all of them make me their primary care provider, and I treat their other chronic conditions the same way I treat opioid use disorder. As we've heard, though, there's a lot of crossover between the brain disease of opioid use disorder and other brain diseases. So the prevalence of depression and anxiety and panic disorder, attention deficit disorder is fairly high in that group, and I feel perfectly comfortable treating those conditions as well. I treat them in all my patients when they have them, but particularly in that group, it makes their ability to succeed with MAT, I think, much more successful. And let me just say that treating this disorder in that kind of a setting is not difficult. I mean, once a patient is stable, it's kind of like treating a stable hypertensive patient and seeing them once a week, which I think we'd all agree would be a little overkill. And also, since the pre-authorization requirements for getting the medication have gotten a lot less onerous, that piece has made it a lot easier on my staff and on my patients to get the medication. There are still some third-party insurers who require a lot of paperwork. I'm hoping that that will go away. That would make it easier for us. The patients who I treat mostly find me on the web. I mean, when I did my waiver about 13 years ago, I checked the yes box, put my name out there. I think these days, if you look up providers, you'll find that I'm in a variety of places, and that's how people find me. I don't advertise other than on my own website. I list it as a condition that I treat. So as you heard me say, my numbers are pretty low. I only treat about 20 people. I could easily treat another 100 or so in my practice. It really wouldn't be that difficult. So this would be in contrast to my other practice setting up in Kensington at Prevention Point, where I have a very large MAT program, about 150 patients and growing. We're employing more providers as we move along. And there I have a lot of referral sources. We have a warm handoff program where I receive referrals from the emergency departments, local hospitals, the police force, the prison system. As was mentioned, we started our own mobile van recently, and we go around to various encampments where we start people, get people inducted, and many of those then are referred back to that program. So we've just gotten so big that everybody up in Kensington knows we're there. You can get treatment. It's not going to cost you anything. And that's really very different than what I see in my own practice. So as I said, I treat this like any other medical disease. I accept insurance to treat it. And unfortunately, those of you involved in treating this disorder in the city know that that's not the case for a lot of practices. A lot of practices charge a separate cash fee to treat F11.20, opioid use disorder. I have patients who come to see me from New Jersey. I accept New Jersey insurances, a number of them, because in New Jersey they can be charged $400+ for the visit. I have a patient who recently left my practice and moved to Altoona. He's coming down to see me because he can't afford the $300 or $350 per visit that it would cost him up there. So of course, if we're going to treat this like any other chronic medical disease, personally I feel we should pay for it that way, and everyone involved in treating the disease should accept health insurance as payment in full. And finally, I'll just say, treating this disease is one of the most gratifying things that I do. In medical school, I really liked surgery. I almost became a surgeon. And I like the instant gratification, the instant result one sees when you do surgery. And most of what we do in preventive care, let's face it, I'm treating your hypertension, your cholesterol, and maybe decades from now you won't have a stroke or a heart attack. Not so here. I mean, within a week, sometimes maybe a little more, you've taken a patient who woke up feeling withdrawal symptoms, went out to find their dealer, had a day involved with, trying to get their drugs. And with buprenorphine, very long half-life, they wake up feeling relatively normal, they take their medication, they treat it like any other chronic disease. They take their hypertensive medications and they go to work. So those are some of my thoughts, and I'll stop there.
Thank you. Ms. Kelly?
Hi, again, thank you, everyone. Thank you to Pew. My name is Regan Kelly, and at NET, we've actually been providing medication-assisted treatment for about 15 or more years. I like to say, and not to be glib, but long before it was popular. And the reason I say that is because we've really been deeply involved in a lot of the, trying to address the stigma, a lot of community engagement work when we were trying to cite our second methadone clinic, which took years because community folks were filing appeals with the zoning board. All of that is only relevant because the result was a really good neighbor policy that I think is pretty critical when you're trying to cite a lot of these programs in neighborhoods. I think there's still stigma and still community resistance to doing so, but I understand it. I've listened to the community people, and you have to kind of find that good balance between the need for treatment and the need for people who see this every day in their own communities. So we have the 2 methadone sites. We have a 3rd site where we provide buprenorphine only, and also the new program that Commissioner Jones referenced called Access Point. And for those of you who are dealing with people, it's at 5th and Spring Garden. It's the first door facing the parking lot. It's 24 hours a day, 7 days a week, walk in. It's essentially a safe withdrawal management program, although people do not have to be in withdrawal. They can certainly be seeking treatment after managing some withdrawal on their own. But most people coming in are in withdrawal and need that immediate access to some kind of initially comfort meds to help manage all those symptoms. That's what we do while we're waiting for the doctor to come in. Currently, we have the doctor coming in once a day for about 5 hours. We're about to add another chunk of time in the morning because people who wait overnight sometimes have to wait until 2 o'clock in the afternoon to see the doctor. But then the doctor is the one who prescribes the buprenorphine, and people will leave having been inducted onto buprenorphine. So there's a lot of work going on during that whole time to assess the next level of care and work on making those referrals and doing those warm handoffs. We will pick people up if we need to. We certainly will drive people to the next level of care if needed. I would say we've been fully operational since about July. There was a period of time where we were waiting for final DEA approval, so we were seeing people only with alcohol use disorder for about 3 months prior to that. But we've probably seen over 2,000 people in that short period of time, and it continues to grow every day as the word gets out there. So, please take that word and in your work, continue to educate people that it's there. It really is a critical resource towards that concept of treatment on demand. When people are feeling, I've made that decision, they can't wait, another week to be seen or to have those processes begin. Just some quick other things that we do. We're also certified as a Certified Community Behavioral Health Clinic, a CCBHC, which is a SAMHSA initiative that I can talk about more if people are interested. But the basic concept is to integrate those 3 components, addictions, mental health, and physical health. In fact, our buprenorphine clinic is at the site that is also a CCBHC. We've run a recovery center for, again, well over 10 years that is fully staffed by peers. We have a residential program, and I'm sad that Commissioner Jones left because I like to remind him that we integrated MAT long before he raised the rates and long before he developed the carrot, because we believe it's critical. It's really a critical part of the continuum. And we provide childcare at 2 of our methadone sites. Again, we're constantly trying to think of what are the barriers to people coming in, and often people who've suffered with addiction have severed relationships with friends, family, relatives, neighbors who might watch their children. So it's very short term, and we work with them during that period of time to find a long-term childcare resource, but it is busy every day. It is well utilized. And I would say that we probably serve with all of those sites well over 800 people at any single point in time, and that's in addition to the approximately 2,000 people that we have served in Access Point thus far. Oh, and I'm sorry, we're also in the prison. We also provide the medication-assisted treatment and the counseling at the Philadelphia prison system. So we're deeply involved in a lot of the conversations around transitioning people out of the prison into the community.
Thank you. Dr. Maman?
Good morning, everyone. I'm Priya Maman, and thanks again to Pew for having us, as well as to the College of Physicians for hosting us. I'm very fond of this institution. So I'm an emergency physician, as well as I consider myself just as much a strong public health advocate. And my involvement in addressing aspects of the opioid epidemic really just was driven by need. The difference between me and my 2 colleagues on the stage is I don't have my own patients. I'm not asking people to come in. People find us because the emergency department is really the only point of universally accessible care. And the emergency department, certainly in this city, but across the country, really have been on the front lines of the epidemic as it developed. And I've been practicing for 14 years. And in those 14 years, I, as well as all of my colleagues in the emergency department, have seen every step of this. And whether it may be considered a character trait or a character flaw, we sort of need the instant gratification. We need as emergency physicians, we need to say, okay, this is a problem, how do we fix it? And where the ED sits, not only in a city and in a community, it is at the intersection of so many systems. And what we can see, I think, clearer than many is where all of the gaps lie and where all the barriers exist, and what every single one of our patients, whether or not they have opioid use disorder in any case, they end up in front of us because some part of the system around us has failed them. And so as I was starting to see more and more, as my colleagues were starting to see more and more, we kept saying, we need help. We need help to deal with this because, as our colleague before said, we have been trained in a very specific manner, which is there's the physical health side and there's the mental behavioral health side. And those who exist in the purely physical health space side really have no control or power in the mental and behavioral health side, and vice versa. And where the emergency department exists is exactly in those two houses. And so it became more and more like, somebody please help us because this is getting really big, and we know very clearly we can keep people alive. Our paradigm is very binary at the beginning, like alive, dead. Everybody must be alive. But that lasts however many minutes to hours. We know that naloxone, by definition, will put someone into withdrawal. And we know, just as someone is released from prison is at a very high risk of overdose, someone who's released from the hospital is at very high risk for overdose, and the emergency department cannot reach beyond. And so that really was the motivator for the vast majority of my efforts, and the motivator to really try and give a voice to my patients who could not make it through the gauntlet that is ending up in front of my other two colleagues on stage. It is a very difficult process, and I think the realities of that process is not always as clear to one side of it. And traditionally, all of the access issues, all of the funding, all of the support has gone to the treatment side. And we're only now sort of stepwise sort of recognizing to be in the treatment side is already having proven yourself to have, the only way I can keep describing it is you have run the gauntlet. But for all the people that need to get there, there needs to be so much more support. And so I see so many familiar faces in the audience, and that is a testament that where the emergency department is interdisciplinary by nature. We work side by side with social workers. We work side by side with treatment providers, but we also work side by side with the community. And I have very much tried to engage every part of the paradigm outside of the emergency department to figure out how best to help my patients and how best to help the community. And I think that has been perhaps a more novel approach. The health system is very used to being within, and we sort of look within and we rely on within and we focus on how things are reimbursed and how patients can get in. But really in this epidemic, in this city, it's been voices and it's been experience and it's been the integration of community, integration of public sector and private sector and our policy experts to really say at every step where we may feel that stigma we're getting a handle on it. The truth is, where I sit, every step of this is seeping with stigma, and every step requires education, and every step requires a thoughtful process. And I think it's all of us together and all of our voices that have really made some great changes in this city, for sure, but a lot more needs to come.
Thank you. So you all represent a different place where an individual may access treatment. Can you talk a little bit about care coordination, what you've seen working here in Philadelphia, and what do you think needs to be strengthened? I don't know if Dr. Bauman, you want to start, because maybe people come into the ER and then you are helpful to move them.
Yeah, so it's very interesting. So care coordination as a concept is critical, right? But here again, there's the care coordination that goes with someone who has brittle diabetes. There's the care coordination that goes along with any number of physical health problems that is embedded in the payer side. The insurance knows how to compensate for it. It's a set process. It's a much more difficult process in the mental and behavioral health space. And I think it's a bit late, at least in the spectrum of how we've been addressing the epidemic. It is not as cohesive and it is not as streamlined as it could be, and that has been one of the barriers. So integrating certified recovery specialists or peer educators into emergency department in some cases has been very successful. But as we know in the emergency department, we either reverse them in the emergency department or they just arrived having been reversed. The first step in their mind, the most salient thing in their mind may not be starting treatment. The most salient thing in their life may not be starting treatment. It can be housing insecurity. It can be making sure to keep their job. It can be any number of things. And so to approach it in this kind of stepwise, like, okay, now you're gonna come to the ED, and the ED is gonna put you in treatment, and then everything's gonna be better, does not take into account the life of each individual, and everybody is different. And so here again, where the physical health side and the mental behavioral health side is separate, we just don't have as much of a reach. We as the emergency department don't have as much of a reach. So we rely on the interprofessional group that works in the department, and that includes very much case manager and social workers. But those, it's very easy in the setting of discussions around the opioid epidemic to just assume that anybody can focus on those with substance use disorder or opioid use disorder. But remember, these are emergency departments in an urban center, and so people may come in shot, and people may be having strokes, and people may be having heart attacks, and people may have appendicitis, and any number of those things. And so the requirements, the sort of wide breadth of knowledge and understanding of the systems, that is one thing for CBH, that is another thing for private payers, that is another thing for those who are from out of state, is just a daunting amount of information. And so in the emergency department, that's, again, another barrier to true care coordination, because it requires an exquisite knowledge of all of these different systems that do not necessarily adhere to one common denominator. It's very different for different people. And so it becomes, again, in the setting of the emergency department, an almost insurmountable barrier depending on the situation. And it's not that every single person wants to hang out in the emergency department for 8 to 10 hours. It's not that the waiting room is not full of other people, and it's not that ambulances are just gonna take a lull, right? Everything is happening in real time. And so where I have said for years and years we need help in this environment is very much because we see the worst cases of it, right? We see the people who have declared that they are in a life and death situation, but the system has not come up to seamlessly help us make sure to not only keep them alive, but to keep them safe. And so, the emergency physicians in this city, that we have been among the strongest and most vocal champions for our patients and for our community, and that starts with harm reductionist techniques of, again, our main focus is to keep people alive, but then in the interim, we're trying to sort of bring awareness to all of the different barriers that they're facing as they take these steps that have been decided in sort of silos or have been processes that have been in place for decades and have not been so quick to adapt to the changing needs of the community and even the changing mechanisms of the health system.
Would you like to?
Yeah, I think it's interesting to go in this order because I think, well, I totally agree with everything you've said, that we're a little bit step further down the chain, so I have a little bit more of a care coordination component built in different ways because we see people longer, number one, and number two, because they have made that choice to seek treatment. That said, it is far from perfect and definitely needs a lot more work. And again, we're in an interesting place, NET, because we have 2 sites that operate the way every other provider in the city operates. And then we have this CCBHC, which has built into the model a requirement to have a strong care coordination component. So it's a little bit easier at that site. Unfortunately, in terms of MAT, that site has about 50 slots. It's our other 2 sites that have hundreds of slots. But we do have some mechanisms built in and required regardless. First of all, we implemented some things a couple years ago where now we do structured screens to identify major depressive disorders and suicide risk. We're finding, much like everybody has said all day, that you know, the population is skewing much more dual diagnosed than we certainly thought so 10 years ago. Maybe it did 10 years ago as well, but we're getting better and better at identifying that. So again, we have some internal mechanisms where we bring in psychiatry and people can see a psychiatrist. And even if people need much more intensive mental health while they're also dealing with the addiction, we can make some referrals for that as well. I think where we're a little bit weaker is the integration of the physical health. Again, we try very hard because people obviously see a doctor while they're getting MAT and get blood work and urine work and other things. We can triage people, and we know people who are at higher risk to make sure they also link to their PCP. What we find is that there's probably different buckets. People for whom years and years and years of addiction and living on the streets and all kinds of challenges, obviously, they probably haven't seen a PCP in years. They probably don't even know who their PCP is. And certainly for the population that comes in uninsured, and we do have a benefits manager who links them to insurance, they have not seen a PCP. So that is our first step with a lot of people, is just to either get them on insurance and link them to their PCP, or if they don't, or if they have insurance, link them to their PCP. And then the second bucket is people who maybe come to us from an inpatient unit or from other resources where they might have already had more of a physical workup, or an emergency department where they've had some, you know, recent strong interface with the physical healthcare system. But across all of it, we try to get the physical healthcare information, triage, and provide as much support as we can to make sure we're making referrals, we're monitoring. In the CCBHC, we even help provide transportation. Some of the peer workers in that model can, you know, get in the car with somebody and drive them there. And again, that model has a much stronger care coordination piece and a nursing piece that also has a nursing assistant who, again, after we triage, does a lot more interface with the PCP. And often that'll result in maybe a doc-to-doc consult around, you know, different medications and how they might interact and things like that. But the system has a long way to go to make it a perfect system. I think, you know, organizations that look across all of their resources, because a lot of what I just described outside of our CCBHC site, we're building in just as part of what we think is a model program, and we feel compelled to do it, and we do it within the resources that we have. You know, could we use more resources? Of course, but I don't think you can provide addiction treatment, let alone MAT, these days without doing some of that.
Dr. Welly, can you talk about both your primary care physician side and also prevention point side?
Sure. So in terms of coordination and assistance with care, I have way more of that up in Kensington. I have caseworkers, I have CRC folks, I have legal, I have help with finding housing. Of course, the press focuses on us up there. If you go down our streets, you'll see overdoses left and right, and everybody carries naloxone. So your chances of getting revived up there are a lot higher than they are where most of the deaths in this city are occurring, which is up in your bedroom down in South Philly somewhere, or wherever you may happen to live. So from my perspective as a private physician, I could really use, as I alluded to, assistance from those folks, insurers, in finding me. In December, I got a letter from IBX, and I was thrilled. They said, I guess they identified me as someone who provides MAT, and they said, is it okay if we list you as an MAT provider on our website? I said, yes, my name begins with B, put me on top, you know? And most of my patients find me through their insurance provider. They don't find me on all those other search engines out there. They find me through their insurance website. And so I would love it if IBX follows through with this, and some of the other private insurers in the state, in the city, do the same thing and make it easy for these patients who are dying in their bedrooms to find me the same way it's easy to find a gynecologist or an endocrinologist or a primary care provider, you know, listed up there on the top of the website. And that also in a way helps normalize the diagnosis. It's like, oh, this isn't some strange thing. It's right up there with my gynecology appointment. So put it there, make it seem, you know, like the rest of your chronic medical conditions, and make it easier to access my services.
Can I add one thing? I'm also going to sort of say something optimistic despite all the challenges, because it's hard sometimes to stay optimistic. I really think the whole healthcare system is so focused on the concepts of population health management and social determinants of health, and every indication is that when you take that perspective, that not only are the outcomes better, but it's cheaper. So I think that's the key, is that we all advocate that what we're talking about, you know, getting people linked to housing, getting people linked to legal support, you know, all of those social determinants of health it's better for the insurer to support that. And I think lots of insurers recognize that and are doing, you know, for me, maybe baby steps, but certainly not the public health MCO in this city, because it's incorporated as a nonprofit, and all the any kind of you know, it gets reinvested into the system. But that concept, I think, is sort of giving me some hope, and we've been talking with our staff a lot about that, focusing on the social determinants, you know, having an impact on beyond our walls. Makes a difference. It not only makes a difference in the lives of people, but it is more economical. It is more efficient to do that. Intervene early, intervene effectively, and you will save money in the long run.
Yeah, I would just add to that. I mean, the insurers do give me a number of assistive services when it comes to helping out with my patients with asthma, with diabetes, with hypertension, the elderly who may need additional services. They remind me when the folks haven't picked up their medications. They offer to send out nurses to help people who need help at home. And if that same sort of wraparound could be incorporated by the private insurers with dealing with this disease, that would be another thing that would be really helpful.
Definitely. So you mentioned, Regan, you mentioned a little bit about about population health and the social determinants of health. Can you talk to us a little bit about connecting folks with these non-medical type services, and what are the outcomes that you're seeing for people when you connect them with the
I can talk about doing it. It's interesting you're asking about the outcomes, because we just started a process to try to take the folks who have been getting the additional support via the CCBHC and the fact that we do this same kind of treatment in a non-CCBHC site, and we're trying to see if we see a dramatic difference. So hopefully we do in terms of outcome. But I can certainly talk about the first part of your question was the process. Is that? I think I'm going to refer back to what my colleague said. It's very complicated when you take that approach, because there are so many systems and there are so many needs, and I don't know if anybody could be an expert in every single one. So we really try to do both a lot of training at the ground level, et cetera, et cetera, et cetera. But we also try to do a lot of partnership building, so that if you're not an expert in housing, we have memorandums of understanding with housing resources, and people can be called in to consult, and is this person eligible for A, B, or C? And if they're not eligible, what else could they be eligible for? So we take the approach that we want people to know as much as possible about as much as possible, but recognize that they can't know everything about everything. And so that larger systemic approach of partnerships, memorandums of understanding, is ongoing as far as I'm concerned. And then I think the other thing that we're trying to do more of is that warm handoff approach, because I think in terms of care coordination, really making sure, it isn't just a token to get to your next appointment. It might be, an actual ride with the person who just spent 2 hours with you, who knows kind of the whole picture of what we just talked about, and they can kind of help, make it that you don't have to repeat your entire story over again. They can kind of ease that transition and do a lot of things to make sure the person not only physically gets there, which is a big part, but hopefully that it sticks. I think that's another big part of care coordination.
So let's talk about stigma. Our last panel talked a lot about stigma, and maybe each of you can address it from maybe the provider perspective and finding other providers willing to provide MAT, but also from the personal, individual perspective, and from the perspective of their loved ones around them. So Dr. Bauman.
Oh, I feel like it's so giant, that question. So I think there's so much more awareness now, and I think there's just the willingness to listen is already a big step. But I would say the fundamental pieces are inherently biased. I think the separation of physical health and mental and behavioral health in systems is a biased system. It's treating mental and behavioral health as if it's different and it needs different systems and it doesn't get paid the same way. And an emergency physician, in my case, can't make the decision that somebody needs those kinds of services. It requires all of these other things to happen before they get those services. The idea that addiction resides in mental and behavioral health space as opposed to the physical health space is biased. It's not taking in the evidence that we're well aware of and all of the literature that shows that addiction is a chronic disease, just as diabetes, just as hypertension. I think having to prove yourself, so I'll give you an example, and this is something I think that has changed, I think, a lot because of the emergency physicians are like, well, what are you guys talking about? But someone comes in, requires reversal. We know full well naloxone does not work for anything other than an opioid overdose or opioids in general. And the question I get is, do you get a positive urine drug screen? Like, no, but they were blue and now they're breathing. So to me, that's fairly clear that there were opioids involved, right? No, we need that urine drug screen to show that they need services. To me, again, I am short attention span, immediate gratification kind of person. It's like, that makes no sense. Like, what does that mean? And they need help now, and stop telling me all these different things that need to happen. That's bias. We would not make a diabetic prove that their sugar will get to 600 if they don't have medications, right? We just have these other ways of knowing. And so I think if you were to speak to then just the general medical world, just something like methadone is very specifically for psychiatrists. Buprenorphine is very specifically for those who have X waivers, or in the emergency department if you're treating withdrawal symptoms and you can give 3 doses. But just that step implies that there's something else, that there is a group of people who will do this, and that's what they do, and it's not all of us. And some of our efforts have very much been to integrate the ideas of the principles of addiction and the basic understanding into medical education, into graduate level medical education, to say this is not just this one house that deals with it, because that is also a barrier. If you have a limited workforce, and you're trying to get everybody into those people, and the difference is the emergency department works 24 hours a day, 7 days a week, when people live 24 hours a day, 7 days a week, but the systems are not there 24 hours a day, 7 days a week. We're in this position of, they need it now. It's not convenient for you right now in the treatment side, but we need some other options. That is another. I just think at every step there is implicit bias, which is, this is different, we treat this different, we approach this different, and so it reinforces this idea that this is not just a regular medical condition, it's something else, and that it's easy to be like, I'm just, that's somebody else's problem. And what that does on the patient side, I would say, what I see is it's just like hit after hit after hit of surfacing for a second and really wanting help and needing help. And it just being already, that surfacing is a difficult step. Already reaching that moment is fleeting. We know that. And if we cannot, and that's what I have really focused on. We have these fleeting moments and we must capitalize on them because, again, in general, but with fentanyl in the system, there is no control. And the next dose, the next hit could be the mortal one, right? So we cannot keep wasting these opportunities, and we have to really mobilize faster. And I will say, the medical system is not one that changes quickly. It's not one that changes paradigms fast. And in the setting of an epidemic, it, I think, has shown all of the limitations of the medical system, of the public health system. It has shown where we just need to step it up and be faster about it and not continue to live in these houses. Well, this is how we've done it for 20 years, and so this is how we will continue to do it. Our neighbors, our community, our systems demand something more, and there are those who have stepped up and those who are still held back by the infrastructure that exists.
So I want to talk a little bit about specifically the stigma of people who choose to take medication and seek medication-assisted treatment, because we've been in that fight for, again, well over 15 years. And for years, everybody at NET wore these little buttons that said stigma with a circle and a line through it. And again, when we tried to cite our second clinic, it took years to cite our second clinic. There was actually a lawyer who provided, I hope this is not too politically incorrect, pro bono hours to the community group to keep filing appeal after appeal after appeal with the zoning board. And he ran for some office. I don't think he won. And his campaign slogan was, "I fought the methadone clinics." This is quite a few years ago. So fast forward, the first time I heard then candidate Mayor Kenny, actually used the word methadone in a public sort of dialogue he was having, I ran up to him afterwards and wanted to shake his hand. I thought his handlers were like going to take me to jail because I was like, I can't believe you said methadone. But I feel like it takes that kind of leadership, certainly the leadership of our Department of Behavioral Health to just keep pushing that message, much like Commissioner Jones was saying, the conversation they've been having with residential providers is this isn't an option. That at this point in time, what we know about medication-assisted treatment, it just can no longer be an option. You can't be a provider in this system and say that you're not going to provide medication-assisted treatment. However, I also understand that runs long and deep in the addictions community. There are years of history. In fact, I wanted to say to an earlier question when I was still at the table, that even the first or second charter of Narcotics Anonymous said that people on methadone cannot participate in Narcotics Anonymous meetings. Now that's been changed, but it's just a great indication of how long and deep this divide is, even within the addictions community, that people who are taking medication were seen as not clean. And even that word, you know what I mean? People are either clean or what? They're dirty, So this stigma issue has been something that we have fought for a long time that I feel really passionate about. And when I was actually promoted to CEO, I will say even within NET, and this is not, an indication of anyone's previous leadership, I think it was, again, an indication of where the system was for many years. But we had on our quote-unquote drug-free side an annual recovery event that the people on our medication-assisted treatment side wouldn't come to, didn't want to participate in, et cetera, because they felt so disconnected from the quote-unquote drug-free side. And they ran as two separate divisions for years. So my effort when I first moved into this role 5 years ago, and it took several years, but we are now at the point where everybody embraces our new mantra, which is that everybody's path to recovery is a valid path. And there's much more integration between the MAT side and the drug-free side. And it really just feels like more of a seamless system. But so I wanted to kind of offer this perspective that it's been a long-standing, traditional kind of thing that takes a lot of work to kind of educate people and bring people along and do it in a way that kind of recognizes, their passion. A lot of the people at NET who were resistant or concerned were some of our peer specialists who achieved recovery without medication and felt really strongly that I didn't need it. So it really took a lot of kind of education and support to kind of get everybody to that point. So.
Dr. Barclay, any thoughts?
Yeah, education, super important. I'm sure everyone in this room accepts opioid use disorder as a chronic disease, but the public at large, our politicians, I would say most of the physicians that I know don't accept it the same way they do endocarditis or hypertension or some other disease that it's easier for them to measure. But talk about measurement. I mean, the brain science has come such a long way that we know that this disease is not a lot different than any of those other diseases. It's nature, nurture. It's about either side of 50% what you were born with, either side of 50% what you were exposed to. The same way it is for type 2 diabetes, for hypertension, and for a variety of other diseases. And the relapse rate for this disease, I mean, there's literature out there. It's basically the same as it is for hypertension, as it is for cholesterol. They really are no different when you start to look at the data. So I think educating folks that it's not their fault. Twin studies have shown us for years that one twin who doesn't have knee surgery and winds up on Percocet doesn't have a problem. The one who does is off to the races. So people need to realize that. It's not a choice. And incorporating the treatment into general private practice, as I do, and treating it, I think, like any other disease, and telling the patients, really, this is the truth. This is how it is. You wouldn't expect a patient with diabetes to wean off their insulin, and I don't necessarily expect you to wean off your buprenorphine. Now, if you're young, and it's been a matter of a couple of years, and that's what you want to do and you're able to, then I help patients do that. But at Prevention Point, I have patients who've been using drugs since they were teenagers, and now they're 50 and 60. And if we follow the methadone model, they will probably go to their grave dying of some other disease on their MAT. But that's the nature of the disease, and we need to educate everybody, particularly providers and politicians, that that's the case.
Thank you. Yeah, yes, champions in the audience. So let's take some questions from the audience. I'm sure you have some for our panel. We have a mic in the back. How about right up here? Or there's a mic right here behind you, right here. Oh, so then everybody in the back can hear you. Thank you.
I'm in long-term recovery. Came up with in the abstinence-only model. In terms of your history of NA, the original folk in NA here in Philadelphia that moved from AA to NA were abstinence only. Why is there a push to make something that has been working for thousands of people change for this new crop of addicts? I'm sorry, substance use disorder people.
I bet you we all have something to say. I mean, I don't know if it's so much a push as much as it is an expansion. And just believe very strongly, based on the medical science, that some people need that to achieve recovery. Some people need that extra support of medication.
Why does my meeting have to adjust to them? Why don't they start their own meeting?
So I think this goes to...
I think that idea comes largely out of the fantastic success that NA has had with helping alcoholics stop drinking. And there's a lot of... I'm sorry, AA, excuse me. Stop drinking. And there's plenty of data out there to support that. Unfortunately, in the case of opioid use disorder, abstinence is not supported by data. The relapse rate for somebody who tries abstinence after a 30-day inpatient program is 26% on day one, 2/3 at the end of the month, And by the end of a year, over 90% of them have relapsed. So in this disease, it seems to be a little different, and the data just don't support abstinence for most people, at least not initially.
And I would add, I personally wouldn't think there's a problem with having different kinds of NAAA, you know, purely A, purely B, purely C. My earlier comment was that there was a point in time where people did not view people on medication as being in recovery. And I think that it is a path to recovery. So, you know, you can have multiple kinds of support groups, and maybe some are exclusive, maybe some aren't. You know, I think there's, again, multiple paths. But I feel very strongly that choosing to seek recovery through with the support of medication should get equal support from the system and equal recognition for the work they've done.
We had another question right here.
Hi, I'm a project manager with the Independence Blue Cross Foundation here, and we've heard a lot about stigma today. We actually have a community-based campaign called the Someone You Know campaign that is a collection of stories of people in long-term recovery or mothers who are supporting children in recovery, or unfortunately people who have lost loved ones. And we also have recently started to collect some stories around individuals who are using medication, because we understand that that is, as we've talked about today, a very large barrier in a lot of communities. From the provider perspective, I'm curious about whether this is the type of stigma that you're experiencing with some of your colleagues, whether it's a judgment of the individual, or if the predominant stigma is around prescribing and more that route, if that makes sense, and how our campaign and the messages that we're trying to bring, whether or not those audiences would be receptive to those kinds of storytellings.
Just clarify one thing, when you're saying the stigma around prescribing, that's MAT? So I will say, you know, I think there's stigma and I hate to sort of sound like such a naysayer, but there's stigma coming from all directions. I mean, the abstinence only, I was actually very surprised at how strong the abstinence only voice is among the communities that I work with. And it was, I mean, just the strength of it was quite striking to me. In that it's the same thing of, we wouldn't say there's only one medication or there's only one way to address any chronic disease, but within the community there is clearly, there is the right way to do it. And so it makes anybody else feel like they're not doing it the right way. I think in terms of the stigma from providers, there's twofold. One is that the nature of the disease includes relapse. And I will speak to my crew on the front line, it becomes, with the high recidivism and the sense of not necessarily hopelessness, but just so little that you can do to help in that moment, over time it becomes quite grueling to sort of have people come in by the ambulances, pull people out of cars, we bring them back to life and they're like ready to go out the door. Or people, I know my colleagues who are hospitalists, people who have very significant medical issues, may or may not be related to their drug use, but they're not staying in the hospital, they're not behaving the way we want them to, and it's because, but it's our limitation of not really understanding their addiction and their withdrawal and their needs in this other chronic disease space. We're focused on their cellulitis or something like that. And so I think, you know, it's very easy for those of us in certain perspectives to fall back on the data. The data is very clear. The data tells us what to do. It's harder to get different people to feel that, right? And I think that's where the stories and that's where the real life lessons teach us a lot. And I can say, I mean, like I say, there's so many colleagues and friends in the room, and that's where I've learned the most from. You know, it's from where I say the health system is very slow to adapt. The community organizations are very fast to react. And so, you know, we have my dear colleagues from Pathways to Housing, and we have mental health partnerships, and we have harm reductionists, and they are, I watch them very, very closely because they can adapt and they can, I think we're all old enough in the room to understand this. I said this to my residents the other day, they didn't understand it, but to MacGyver a situation. and that's how the emergency department works. We sort of put together what we can. But I think the lessons to address stigma and the lessons to really understand a person or an issue as a whole, as opposed to one piece, are the key parts to it. And those stories and those lived experiences and those just the lessons of life bring those things to life in a way that the data cannot.
Anyone like to add for Blue Cross?
No, just I was going to say something very similar in terms of the stories of people who either their own lived experience or family members of people who have either had lived experience and fortunately are still living or not. That's a very powerful way to start to educate the community about the fact that this is hitting every sector of society. You know, I still hear a lot of resistance in the community. I'm not totally naive. As much as there's been progress, there's a lot of work to do. But I think the more people sort of can see, oh, it could have been my kid, you know, or it could have been me. Hopefully that has some impact.
So we have a question from our live stream audience. So from Public Citizens for Children and Youth, what are some of your most successful interventions and supports for children of individuals who have an SUD, and what resources are still needed?
Can I jump in? For children? May I jump in first?
Sure, these are children of individuals who have an SUD.
Right, and actually, the reason I'm jumping in first is we just got a federal grant to address that very issue and trying to look at children from two angles. And so we're going to work with parents who are in our programs. And again, we've done some things previously. We've integrated a voluntary parenting program. We also have a large child welfare continuum. So we've used a lot of those resources. DHS, our local child welfare, funds a parenting collaborative program. And we've used those dollars to offer parenting programs to people who are in our substance use programs. On the converse side, we just finished training a big segment of our child welfare case managers on how to administer Narcan, because they're interfacing. If 80% of the population coming into child welfare have been impacted or affected by substance use, then they're interfacing with people who are, you know, either currently suffering from addiction or at high risk. And the focus of this federal grant, if the federal government ever opens, we'll get some of that money, is twofold. One is both the children of people who are currently with us. We want to intensify that focus on parenting, but we're also trying to find a core group of kids in the community who are impacted more by the sort of vicarious trauma of living in these communities. So hopefully we'll be implementing that soon. It's a 3-year federal grant. And interestingly, I'm sorry, from the Office of Victim Services. So defining the children as a victim, I thought was an interesting kind of way to be creative about how they're using some of the dollars that are available.
Definitely. So I know there's one question that right there at that table. Yes, thanks, Megan.
I'll be quick. My name is Abraham Gutman. I'm an opinion writer at the Philadelphia Inquirer, and I write about drugs and addiction. And I have actually 2 really quick questions. The first is, there is a difference between the way we treat addiction and other diseases, that is the law. The treatment is much more regulated. It's in ways that have no relationship to the actual treatment. So I wonder, what do you think is the role of practitioners, physicians, in movements like X the Waiver, liberating methadones out of OTPs, and what can practitioners do? And my second question is, what do you think is the role of an overdose prevention site in continuum of care and in treatment? Thank you.
You want to take the physician?
I couldn't hear it. I can't hear out that ear. So why don't you go
I
ahead?
can start. So, you know, the paradigm of physicians is very one-to-one, and it's very protected and confidential, and that's how we're trained and that's how we behave. And that's where doctors are the best, right? Like it's that direct patient contact and it's that individual. But I think because I started in public health before I went into medicine, there is a different way of thinking where if you put each individual experience like that together, you get a different picture. And I think doctors compared to lawyers, for example, have not ever been very strong in advocacy work and kind of working on that policy level. It's again, you know, the clinicians among us, it is, I'm dealing with this patient and they are my primary focus. I think this epidemic has made some of us realize that so this was, I can speak for myself, the voices of my patients were not being heard. And these stories were not coming across, and these ridiculous things that I think anybody could hear it and be like, that's the stupidest thing I've ever heard, was not being heard by the people with the 50,000-foot view who are making policy, or propagating policy. So I think the biggest lesson for me is that part of our role as physicians, part of our role as providers, is to make sure that, yes, we address the needs of that individual, but then we make sure that other people are aware of the barriers in access, of the limitations of the system, of the things that our patients are dealing with, because they as individuals may not be able to get their voices heard on larger scales. And I think that role of advocacy and that role of engaging in larger systems has not been a paradigm of physicians traditionally, but it now we are, I think, as a group, and perhaps those of us of a certain age are much more aware of that being a continuum of our responsibility in terms of patient care.
And so Dr. Barclay, would you like to chime in on the?
Sure, yeah. I mean, the restriction on access that comes from the regulatory pieces that we have around getting providers wavered to do this is improving. I mean, these days, nurse practitioners and physician assistants in Pennsylvania and many other states can provide buprenorphine. I think that's a huge step forward. I still don't know why they need to do 20 hours or 24 hours worth of training, whereas physicians need to do less than half that, and when I did it, it was less than half that. But that's an improvement, and in 2016, when we lifted the number of patients I'm allowed to treat from 30 the first year, 100 the second year, to now 275, which I'm certified to do. You have to work in a certain kind of setting to do that. I mean, I qualify because of my association with the work up in Kensington. I don't think I would in my practice in Center City, but quite honestly, that's a lot of patients. So that's probably about as many as I could handle. The logic of it, of course, makes no sense at all. Where does it come from? I have no restrictions on the Percocet prescriptions that I can write, et cetera, and everybody wonders about that. Although we're getting a little better around educating physicians on opioid prescribing and limiting the number of pills we prescribe and so forth. But yeah, I think it's getting better, but we still have a ways to go with lowering the barriers.
So we only have a couple minutes left. So I wanted to just, before Commissioner Ingram so appropriately raised the fact that every one of us knows someone who has been touched by the opioid epidemic. And so as a provider, is there one thing that you can share with us about how we can bring our loved ones, our work colleagues, our friends, and bring them into the treatment system? I'll give you all a minute.
Do you mean if they need treatment?
If they need
Get them in, I mean.
What should we be doing? How can we support them best?
Well, the best, again, it's letting them know it's not their fault. If you have this predisposition to lose control over your Percocet prescription that the doctor gave you 80 of because you had a knee surgery, that's not your fault. And the fact that you can't stop it means you need help, and you should get help like you would for any other medical condition. Just try to normalize it.
Yeah, I also think, and I totally agree, that that's a huge part of it. And maybe even kind of try to be self-reflective about your own reaction to their addiction. Do you know what I mean? I think a lot of families, you know, is it their fault? Is it, or they judge? We've had lots of parents ask us, you know, well, when can they titrate? And of course, without consent, we can't really talk to them. I tell people all the time, that's a conversation that happens between the client/patient and the doctor. Do you know what I mean? Like, that's where that conversation happens. But I think even the question about titration speaks to the stigma and things that families are worried about. So I think in addition to telling the patient it's not their fault, the larger community education efforts to make sure that someone actually acts when they see it in their loved one. And then the third thing I would say is really looking for those signs of kind of like that pre-motivation phase. Because you know, you can talk to your loved one over and over and over and over. If they're not ready, they're not ready. And you have to kind of balance pushing them further away by over-talking it. And there are signs and indications of being in that pre-motivation phase, you know, when they start talking about it, when they, you know, maybe don't go out that day and you know, until later in the day because they're trying not to expose themselves to places where they use or any other number of signs of pre-motivation. I think sometimes it's knowing when to act. So that's what I would say.
You know, I will say, I don't have anything as pithy, but I think one of the lessons that I've heard and learned, again, from my friends and colleagues who are doing these efforts on so many levels is love and support goes a long way. And I think Carol Rochester from Angel in Motion, that's everything she does, is just know that she will be there and that she's not judging and she's not questioning, and it is unending. And I think those of us who are parents, just there is the fear and the sort of the wondering of like, what did I do wrong? But no matter what, you will always forgive or get over whatever your kids have done. It just becomes harder and harder. And I think the systems need to be that same. It's not a one size fits all. Everybody is different. Everybody has different stressors. Everybody has different needs. And so, again, just like we would do for diabetics, as we watch them drink a Pepsi in front of us, you know, like, it's like, okay, I'm gonna tell you I don't agree, but I'm not going to withdraw my love, my support, my help, my, you know, sort of unending desire to get you through this. And I think that's the biggest part.
Thank you. So please join me in thanking our panel.
Well, thank you, Beth. That was an incredible and a really informative conversation. On behalf of the Pew Charitable Trust, I want to again thank our distinguished panelists for being here today, including our Philadelphia providers, David Barkley of David M. Barkley Family Medicine, Regan Kelly of Northeast Treatment Community Care, and Priya Maman of Thomas Jefferson University. And of course, there was our first panel of officials, Eric Halsey of Allegheny County Department of Human Services, Tim Ingram of Hamilton County Public Health, Marissa Kaplan Dobbs of New York City's Department of Health and Mental Hygiene, and I know he's not here, but a thank you to Philadelphia's David T. Jones of the city's Department of Behavioral Health and Intellectual Disability Services. And again, Beth, I'd like to give you a big thank you to you for serving as our moderator for both panels. I also want to thank all of you who are here in the audience, those watching on our live stream, and those participating on our Twitter for joining us and for taking part in this conversation. Whether you work in healthcare, public safety, law, academia, human services, or government, or you're simply a concerned citizen, we hope today that the lessons learned were helpful. If you would like more information on Pew's research on Philadelphia and substance use prevention and treatment, please visit our website at pewtrust.org/opioids, where you can also sign up for our monthly newsletter to stay up to date on our latest reports and findings. Again, thank you so much for joining us. Please feel free to stay and mingle and talk more. Thank you.